Thank you, George. Hi, Alan. Hi, Ken, Jaideep, Aya. Thank you for giving me this topic to present. My name is Ghafoor, and I come from Malaysia. Many of you have come to where I live in Langkawi, and those pictures there are basically some pictures of where I stay. I don't own the helicopter, but the hospital owns the helicopter. But when you come, you are most invited to come on board. So Malaysia basically has been having some good results in their COVID lately. We've been hitting single digits over the past couple of days, and we are ranked at number 26 in the world. And this is mainly due to a few key interventions that were done. Number one was the involvement of the military and the police to enforce lockdown in Malaysia quite aggressively. And number two, it has been the concept of targeted screening, in which Malaysia doesn't have the capacity to screen the whole population. But what they do is we have a system where it is based on epidemiological studies. And when there is a group of people that are positive in a particular area, then that particular area is locked down by the military and everybody there are tested. And those that are positive are taken to hospitals and isolated from everybody else. So by doing that, we have come down to about 1.2% in our infectivity rate from 8,600 people. And our new cases that have been detected was about single digits at about 3 or 4 over the past couple of days. So currently, I'm working in Penang. As you can see the map below, it's about 100 kilometers from Langkawi. It's a slightly bigger island, but I seem to be working in only island-based hospitals at the moment. So let's start and let's get down to business. So this is a very complex slide, but it presents basically the entire paradigm of laparoscopic hernia in one particular slide. So from the top, you can see that pre-peritoneal space was introduced in 1966, the TAPP technique in 1991. The indications for surgery for groin hernias include bilateral, recurrent, unilateral, direct, indirect, and femoral. The only contraindications used to be patients that are unfit for GA, they still are. Patients that are peritonitic, I believe it still is. And over the past couple of years, the last two indications have changed. It used to be contraindicated for patients who have incarcerated or large scrotal hernias. But now with improved technical abilities and also better instrumentation, the last two indications have become a more relative contraindication rather than an absolute. You basically need a pre-op fitness assessment, and you need to treat any comorbidities that the patient might have, including any constipation or any urinary problem that might have. You have the TAPP approach, you have the TEP approach, you have the IPOM, and I'll also be describing the ETAP, and I'll be including the SILS and robotics as well in this discussion on when we can do and when we can consider performing these procedures. Antibiotics, catheter use, and GA basically have all been described before. In our practice, we don't catheterize all our patients for laparoscopic hernioplasty. We make them go to the bathroom just before they have the operation done, and all cases are done under GA. In a nutshell, laparoscopic hernia basically over the past decade or even before that has proven to produce better short-term quality of life results as opposed to an open hernia. And there has been a lot of research done, especially in terms of earlier return to function and post-operative pain. So, and the evolution of hernia repair basically is something that everybody knows. You have the brick repair, the open surgery, the tension-free era, laparoscopic surgery, robotic, the reinvention of tension-free, in which we analyze this concept of whether we need tension-free repair, which has been learned particularly in our experience in ventral hernias. We find that in ventral hernias, we don't absolutely need tension-free, but we need to maintain the diastasis as well as the strength of the anterior abdominal wall. The most recent advance that has occurred, particularly in laparoscopy and imaging technology, is the availability of blockchain technology integrated into artificial intelligence and big data. This is basically information derived from on financial platforms such as Bitcoin, in which you insert a pocket of information into a chain, and subsequently you can add on or remove that pocket of information. What this does is it allows for easier machine learning, which has basically become the forefront now in artificial intelligence and the teaching of machines how to perform procedures. So there's also been a dramatic change in abdominal wall repair in the past decades. Patients' patterns have changed. We have got more aging comorbidities. That means patients who are coming in at a later age, patients that are coming in much iller, and the hernia being only a side pathology, but their main problem is perhaps a cardiac, a pre-existing cardiac condition, a pre-existing metabolic condition. And treating the hernia aggressively, you need something to treat the hernia that will not disturb this homeostasis of the patient. The disease etiology also has changed. We understand better regarding collagen matrix, genetic predisposition. Mesh technology also has improved in terms of porosity, barrier film, biological measures, and surgical approaches now has evolved to Endo-Lap, mini-open, robotic. All kinds of new techniques have come into play over the past 2 decades. So what has this resulted in? We have better pre-op diagnosis and workup. We have guidelines now to allow surgeons to basically tailor their approach to individual clients or patients. We have the start of specialized centers all over the world who say that they champion the best techniques in hernia. And also based on all this, we have got improved outcomes. The key element that has come into play is our understanding regarding abdominal wall as a functional organ and not as a static organ. In that sense, when we do laparoscopy, we understand that we minimize our trauma to this functional organ, and therefore we not only reinforce the posterior or anterior abdominal wall, but we make sure that the functional organ, which is the abdominal wall itself, remains intact. The biomaterials also has evolved over the past 2 decades. So let's talk a bit about groin hernias now. More than 20 million cases worldwide, with about 800,000 in the States. Recurrence at about 2%. And you have a population of more than 4.2 billion in Asia, and at about 18% of those population will develop a hernia in some time in their life. So you have a very big pool of patients who have a hernia. From the 1950s to 1980s, you can see that open hernia has been predominant. You wouldn't want to be this guy who is lying down on the table, being held down, even though he has a smile on his face, because you know that he's undergoing a lot of pain during the procedure. Now, what has happened in the 1990s and the early 2000s is laparoscopy has come in play. But has there really been a shift from laparoscopy to the next phase, which is actually robotic sills as well as nodes? I do not feel that that is present. There is definitely be a shift from open to laparoscopy, and there's been a particular preponderance towards robotics. But has there been a major shift between laparoscopy to these procedures? Evidence shows that the laparoscopic procedure is still the most popular way of performing this operation. Now, the EHS published their international guidelines for groin hernia in 2019, and this differs from the previous guidelines that were published by the EHS, particularly regarding unilateral and bilateral groin hernias. The latest guideline states that laparoendoscopic repair is recommended for primary bilateral inguinal hernia, and it is recommended that surgeons tailor their treatment based on experience, national resources, patient and hernia-related factors. The first criteria now is easy enough to understand. If patient presents with a bilateral primary inguinal hernia, laparoendoscopic repair is preferred. And in the previous guidelines, there was a preponderance to prefer TEP as opposed to TAPP. That was mainly due to the fact of a lot of studies that came out that says that there is a small percentage of visceral injury associated with TAPP. But the guideline doesn't specify what is exactly the resources that you should have to perform these procedures, and what type of patient and hernia-related factors are required. So this is basically left to the surgeon's experience and his case-to-case basis. The next development that has occurred over the past decade predominantly is availability of information on social media. Patients now are more educated on realizing, on knowing what type of techniques are out there. They even know the types of mesh that are available. And some patients even come and ask me what type of system I have in my OT. Is it Olympus? Is it stores or things like that? And this is something that is very shocking, you know, because the availability of this information is available. So you're not able to basically tell them that you know best and there's only one technique that you do and you are comfortable with and they should accept it. So this paradigm shift that has occurred in the availability of information and patient accessing it forces us as hernia surgeons to be a bit more, how do you say, flexible in our skills and also our ability to perform the procedures. So let's consider the evolution and which repair is for what. Let's talk about primary inguinal hernia, be it unilateral or bilateral, recurrence and re-recurrence, atypical inguinal hernias, emergency situations, and ideal approaches. Now, the next strong recommendation that comes out from the EHS is that a mesh-based repair technique is recommended for patients with inguinal hernia, and despite comparable results, the plug and patch and bilayers are not recommended because of excessive use of foreign material. And also that is regards to TAPP and TEP, both have comparable outcomes, but it depends on the skill of the operator in terms of what the end result is. So there is no more shift to prefer TEP as it was in the early 2000s as it is now, as opposed to TAPP. And also there is a shift to go back to simple mesh as opposed to the three-dimensional and bilayer meshes that were available in the market towards the 2015 era and forward. So let's discuss these procedures now. You have the open hernia. The open hernia is a procedure like Muhammad Ali. You know, he can try the test of time. You know, he will always be the greatest. No matter what you say, the open hernia will never go away. There will always be an indication for patients that come for open hernia. The TAPP can be described as this fighter, Khabib Nurmagomedov. He's got a very strange last name. He's very versatile. He's able to actually fight with a lot of various styles. And the same way, the TAPP is able to manage a lot of various problems like adhesions, incarcerations, patients that come with obstruction even, you know, it can be managed. The TEP though is basically the procedure that is the most popular in terms of people's liking towards it. And it's a lot like this guy Floyd Mayweather, but whenever he fights, he chooses his opponents. Likewise, the TEP presents very good results with a select group of hernia clientele that comes to us. And then now we have the ETAP, which is like Mike Tyson. It isn't something new. It is something old that is being made popular again now, but it is gaining popularity. You've got the robotic inguinal hernia procedure, and you've got the Seals hernia. Both of these are like actors who are performing in Hollywood to pretend to box. They look nice, they appear to be good, but at the end of the day, they're not real, they can't compete on the real platforms as the classic ones. But this is the current state. Whether or not this will change, we will not know. So obviously we have various benefits of open laparoscopy over open in terms of quality of life and also chronic pain. So that is established much earlier on. But what type of laparoscopic procedures are we going to err towards or move towards? Now, in choosing to learn a procedure and choosing to teach, the panel members are all very experienced trainers in laparoscopy. Alan, George, Ken, Jaideep, Professor Chowdhury. They are all very experienced trainers, and they know that when we go and teach these procedures, especially to new surgeons, we find that the take-up is everybody wants to learn the TEP because they find that the procedure is very elegant and sexy as opposed to the TAPP. But if you see the study that came out of India in 2015, the first graph shows a model of a new surgeon, which is in blue, as opposed to a veteran experienced surgeon, which has a stable operating time in red. The bottom graph, the above graph is for TEP, the bottom one is for TAPP, and the green line shows the moving average as to how much time he takes to perform the procedure. If you see that when a new surgeon takes up TEP, there is usually a dip in the time that he performs because most likely he converts the procedure to open at that time. But you don't see that for TAPP. And when he stabilizes towards the end of case 15 or 16, when the graph stabilizes, after 15 or 16 cases, his time becomes more, how do I say, horizontal. There is not much fluctuations. But it takes them faster to learn the TAPP. And that is mainly because of the familiarity of the intra-abdominal peritoneal cavity and also their comfort levels within that cavity when they perform the procedure. So young surgeons, though they prefer to perform TEP, the trend shows that when we teach it to them, they replicate TAPP better in their respective centers, unless you have a master or you have someone who can teach that procedure one-on-one or one to a particular group in that hospital. But if you just learn it in workshops or on courses and take it back, the replicability of TAPP is more than TEP. So for TEP and TAPP, we know that the only issue regarding TAPP is visceral injuries as well as trocar site injuries. And I have a short video of a trocar site injury that occurred in my center. This resident inserted the varus needle and successfully poked the middle sacral artery, which is below. And then subsequently, I had to come in, find the bleeder, and somewhere there, grab it, and then just cauterize it and pray to God that it stops. And basically that's what happened. All right. So you also have some vascular injuries, but in TAPP, let me just show this quick video where he pokes the iliac vein there. So it bleeds from there. So this was quite controlled with just pressure and increasing the pneumoperitoneum to a bit. Okay, so you also have trocar site hernias for TAPP, which is higher as compared to TEP. Though the number shows only 0.5%, you have to know that even though it's 0.5%, it is a small percentage, but it's a very big actual number. Malaysia has got an airport, KLIA2, we have about 30.3 million passengers, and 0.5% comes to about 1.5 million. So it's still a big number. So you have to be very aware that despite the fact that TAPP is a more comfortable procedure, it has this complication. So what are the recommendations? Now, between TEP and TAPP, whatever said and done, open has still a significant role. And in the last 20 years or so, TEP has been in the forefront for primary recurrences and also patients that have got primary abdominal and lower midline surgery. But it has come to show now that more and more studies are showing that in cases of incarceration and strangulation, a TAPP approach might be better, or a hybrid approach in which you perform a laparoscopy, reduce the contents intraperitoneally, and then do a TEP procedure. So this is a video of me performing a incarcerated hernia. I usually use an energy device, and by TAPP. So it's relatively quite easy basically to perform the procedure by TAPP, because with pneumoperitoneum and an increase in abdominal pressure, once you get the proper lead point, the omentum or bowel contents basically just comes back in. So in the interest of time, I think I'll just move on. So what about patients that have got recurrence from open surgery? You can consider laparoscopy for these patients, definitely. So patients that have got recurrence from open hernia, studies have proven that recurrence and also reoperations with laparoscopy is superior and also results in less pain. But what happens if we are discussing recurrence after TEP or TAPP? What we teach our students, our residents is, it is better for you to do an open repair if you have a recurrence from TEP or TAPP. But you can do a TAPP if you have this recurrence as well. But again, this depends on experience as well as expertise within, which are limited to the center and to the surgeon. So now you have this new ETAP technique. It's not very new. It's an old technique that has come into play, and it's popular among patients that have got lower midline scars and patients that have got a very short umbilicus to symphysis distance. I use this Samsung technique to basically measure this distance. It's normally about 6 inches. So if you have a bigger phone, the distance will be bigger on yourself, and you have a smaller phone, it will be smaller. If it is 25% less than this distance at about 6 inches or 15 centimeters, then I would consider an ETAP technique as opposed to a TAP technique, because it requires a bit more dexterity to do it in that narrow space. If you have, so in summary, basically, whether you're doing TAPP, TEP or hybrid, you tailor make it for the patient and base it on your expertise. If you have something as big as this, you better just refer it to Alan and ask him to do it. So I got some videos on atypical hernias, but let's not go into that. So the changes in the past decade, as you can see previously, the TEP was predominant, but now we can see that more and more indications are creeping into the TAPP. I didn't talk about Inguinal Hernia because of for the limits of time, but there's actually a very small group of patients that will benefit with any recurrence and pain that occur from the primary surgery. So let's talk a bit about robotics now. So is basically robotics going to be the forefront of newer techniques? It is driven by two main factors. One is the education aspect, in which this course is offered in Imperial College in London, where it trains both surgeons, doctors, and engineers to come up with new and newer devices in medical technologies. And this course basically has spurred the development of more technology, and also it is industry driven. As you can see, Intuitive Surgery stock was trading at about $25 in 2005, and it's trading at about $500 now. So there is an industry proponent that is pushing this forward as well. But the main problem is basically the outcome and the cost. The amortized cost on a 5-year lease on a robot to do a hernia case is about $1,042 per case, and it's about $51 per case for laparoscopy. So there's a huge difference. But the more cases you do by the robot, basically the cost comes down. So, but having said that, definitely the technique itself is finer, and it is much nicer to do the procedure with a robot. As you can see, even the peritoneal dissection that is done is nicer with the robot as opposed to doing laparoscopically, and the technique is also quicker. So if given a choice and cost doesn't come into play, all of us would actually prefer having a robot to perform these procedures. So I think I've come to the end of my presentation. I would like to thank everyone. I still remember our Board of Governors meeting in Langkawi in 2019, and our president is there, Sutep, on the beach. And thank you everyone for your attention. I'm sorry to have passed about 3 minutes of time, and I hand it back to the moderators for any questions, please.